have at the moment. I think it started in the early 70s with the laser by Sergio Cavaliere and the Dumont by Professor Dumont. But we have then the launch of the EBUS TBNA scope in 2004, which was really a next step forward. And then we have all the other technologies we are using today, and I will focus on a couple of the most actual developments in that field. So first of all, it's the biopsy. In 2009, the first publication came out that we can use the cryo probes for getting better and bigger specimens from the peripheral part of the lung. And in the field of interstitial lung disease, it's nowadays an accepted technology that when you need of an histological proof of the disease, that you first do a cryobiopsy, because the specimens are 3 up to 4 times bigger than the smaller specimens, and therefore it's the recommended technologies. There we have just seen the launch of ultra thin flexible cryoprobe. It's the 1.1 millimeter cryoprobe, which you can insert into a guide sheet, and that guide sheet then can keep the biopsies. It's not longer the need that you take the whole scope out. So you only have to take out the biopsy, cryobiopsy tool with the sheet. And so this is one advantage. And for me, the second advantage is when you don't want to use it via the sheet, due to the reason that the cryoprobe has only an outer diameter of 1.1 and you use it in normal working channel, you still can suck mucus or blood next to the cryoprobe, which makes the procedure way easier. So we moving now more in the direction of the use of a 1.1 millimeter probe. And there have been trials published that when you freeze a little bit longer, you have to freeze up to 10 seconds, that the specimens are comparable regarding the size, like the size of the specimens you get out with the bigger cryoprobe. So therefore, the generation of probe is already launched. Here you see data from one of our trials where we compared the 1.1 to the 1.9 and to the classical forceps, and you see in the right corner that even the smaller cryobiopsy is clearly better than the flexible bronchoscopy, and you get enough material out to establish the diagnosis in interstitial lung disease. And we also moved now in the direction that we're using the cryo systems for diagnosing lung cancer, because even lung cancer, the oncologist wants to know a lot about molecular targeted options. They want to know what is the immuno situation of the tumor, so therefore they need tissue. So we're using also the cryoprobes nowadays for a tumor biopsy, because also therefore we're getting bigger and better specimens. So the next will be that we're looking forward to technologies where we maybe can diagnose the disease without you taking a biopsy. At the moment, we have the MRI, the ultrasound technology, the CAT technology, but when you see OCT and microscopy, it has a resolution of 1 up to 4 micrometers or even less. So having access to those probes for the bronchial system, you will see more details of the bronchial system, of the alveolar space. So one of the technologies we are using are the OCT, is optical coherence tomography. It's a little probe. You insert the bronchial system, and then these are animal data. These are slices we have got by the OCT. And then we compared it to the histological cutting from the pathologist through the same area. And you really have a nice correlation between what you see the OCT, so what you see real time during bronchoscopy, and what the pathologist shows you later. You see the glands, and this is an important target for the chronic bronchitis option. You see the muscle layers. This is an important target for thermoplasty, what we're doing in asthma patients. you see the mucosa. So it's really nice what you can see with an OCT probe, and especially when we offering treatment options via the bronchoscope targeting, for example, the glands or targeting the muscle layers, then you really can follow your success of the procedure with the help of the OCT probes. And you also can move the OCT probes forward into the lung, then you see the filling of the alveolar space. This is a patient suffering on an hypersensitivity pneumonitis, and you see the filling of the alveolar space. Then when you put such a patient on a corticosteroid therapy and you do a repeated bronchoscopy and the patient is responding to the therapy, you really can see how that filling is reduced, how the alveolar space, how the alveolar area gets cleaned up. So with the help of the peripheral OCT probes, you have a technology hopefully in your hands where you can judge earlier than to lung function control or something if a patient is responding to a therapy. And this is even for me important when you look to all the antifibrotic therapies we have nowadays, which are expensive. So when you have a signal that it works or it does work, you can stop an unneeded therapy earlier, or maybe you can change the therapy when it doesn't work. Therefore, optical coherence tomography offers really good solution. And also be doing endocytoscopy. So these are special scopes. You see it in the upper corner where we have to stain the bronchial system first. And when you stain the bronchial system, then you see the movement. This is part of right bronchial. You see moving. It's next to the moving parts of the, and this is research technologies because we sample from the cilia area to already lost your movement to understand better what happening is there some patient developed cancer. So with the help of the endocytoscope, we are able to take really microbiopsy from specific areas. As mentioned, this is a research technology. I don't know if we ever use that in our daily routine, but nowadays, with the improvement of the optical possibilities, it's possible to do microscopy online in the human body. For sure, EBUS was one of the most and quite successful investments. We have just seen the launch of the slimmer EBUScope. This is the next generation. You see in the lower part, generation 1, and in the upper part is generation 3. So it's the ultra thin or the slim EBUScope, which you see even the size of the scope gets way slimmer. The transducer is getting slimmer, so therefore you can move it more into the peripheral part of the lung. And these are images from animal data. You see these are lymph nodes in the stations 12, 13, and 14. And you can see them, and you can take an EBUS TBNA. So with having the improvement in the size of the EBUScope, we are able now to use the EBUS TBNA, so a controlled biopsy, even more in the mid-third of the lung. And the slim EBUScope will be launched. I don't know, the plan is to launch it at the ERS 2021. Hopefully it will allow that to do that. So even for the EBUScopes, we will have the next generation soon in our hands. So for all of you who are thinking at the moment if they should invest in the EBUScope second generation, don't do that. Wait a little bit, then you can already buy the third generation, which brings you more into the peripheral part of the lung. And we have new needles. Those needles are now available, the 19 gauge needles. And what the big advantages of the 19 gauge needle is that the needles are more flexible. You see the bending of the EBUScope with the 21 gauge needle, so the classical needle, and the new needle, and you really see that the shaft of the needle is more flexible, for the bending is not longer so dramatically reduced. So there is ongoing improvement of the needles, and there at the moment are 4 companies who are offering different needle for the EBUS TBNA scope. That also means that the price is coming down. So EBUS TBNA is nowadays an accepted technology, but also therefore we're seeing more and more improvements. The big issue in the near future will be the nodule business. So these are data from several lung cancer screening trials, and calculate the mean cancer size in all those trials. The mean cancer size is 1.3 centimeter. So we will have screening programs available. Germany will launch that next year. There have been a couple of European areas where it's already accepted and approved, and I'm relatively sure in Turkey you will debate if you should offer patient or persons who have a risk for developing lung cancer screening program. But we have to accept that when we're doing that, we will find small, tiny lesions. And the question is, when we want to diagnose those lesions, what can we do? You see, these are such lesions. They are normally below 2 centimeters, so T1A. And the question is, can we use the bronchoscopy to diagnose those lesions, or do we want to send all those patients to the surgeons for the diagnostic approach? The point is, we know exactly where those lesions are. These are data from the Nelson trial, where they just showed where their cancer lesion in that randomized controlled trial have been. And you see the majority of those nodules, so 60% of the nodules are in the outer third of the lung. And therefore, it's clearly when we want to be a player in the field of diagnosing nodules, we need technologies which bringing us in that area where the target is. In the last couple of years, we have had a couple of investments where we use different technologies to reach those little lesions. We have seen the navigation in technologies. You can go into the CAT scanner. You can use electromagnetic navigation. You can use the EBUS. So there have been a couple of publications, a couple of technologies which helping us to find a way in the peripheral part of the lung. And I think the most common used technology is the radial EBUS. So you go into the segment where you suspected the nodule, you move the probe forward, and then when you are in the lesion, you get even a snowstorm image. This is on the left. That means no cancer lesion reached, or you see it like in the right, my right side, a classical solid lesion. So you are in the lesion and you can take the biopsy. The disadvantage of radial EBUS is that you cannot really steer that probe. So the probe is moving in the direction the probe is running because the radial EBUS is not steerable. So this is the disadvantage, but for confirmation technology that you really reach the area, it's really the best technology. So therefore we have to look for other technology. One of the technologies we have is a GPA system. These are the navigation technologies. This is the Bronco system where you have the online, where you really have your real-time image, you have the virtual image, and when you get lost in space, you just overlay the track into your real-time image. So it guides you to the area, it guides you to the target. So virtual bronchoscopy is nowadays also an accepted technology which guides you to the area you want to biopsy. The problem is a little bit all those technology, and this is a review a couple of years ago from Gerard Silvestri, really shows good yield when you have lesions bigger than 2 centimeters. But when you go for smaller lesions, when you really go for lesions below 2 centimeters, and this is the area we have to go to, then the yield is dropping down. So we still have need for technologies with bringing us to the lesions smaller than 2 centimeters. And one problem might be that the lesion is not longer in the airways, it's more in the tissue. So whenever you follow with every navigation system, you use the airways, you will never reach that little lesion. So therefore we developed the transbronchial nodal access. So this has been the first in human, where we're using a navigation technique to tunneling the broncho, to open the airways in the central part and then tunnel the device directly into the lesion. You see this how we do that. The software calculates us the point of entry. When we reach the point of entry, we just sticking a needle into the bronchial system. We do a dilatation at that point, so we opening the airways, and then we moving a sheet under fluoroscopy control into the lesion. So this is one technology, and on the ERS 2019, we presented our data in 105 patients, and you see we in the patients less than 2 centimeter, we still have a yield of 81%, so quite a high yield for those technology comparable to what we've seen even from CT-guided needle aspiration in a broader spectrum. So it really was shown that the transparenchymal nodal access allows us to have access to smaller lesions. So this is an option. The other alternatives are the robotic system. There are in the US 2 systems on the market. The ORA system for Medtronic and the Intuitive offers the ION system. Both technologies go for CE mark, and even those technology where you use at the end a remote control to navigate your bronchoscope through the body will be available soon. So maybe the robotic system will play a role. The problem is a little bit all those systems, so the lung pro system for the tunneling, as well as the robotic systems, they are not as cheap. So the lung pro for the tunneling, the investment is 250,000 euro. For the robotic system, both are 1 million euro. So these are very expensive. And the question will be how afford such expensive machines for a diagnostic procedure. So at the moment, technique might be even improved further, but that will be costly. And the question will be who is paying the bill. So therefore, I believe investment in such expensive technologies only makes sense when you can do a diagnostic and treat procedure in one session. So therefore, we're working a lot on thermal options to destroy lung cancer. And therefore, there might be cryoablation, a solution, radiofrequency ablation, vapor, microwaves, or a hypertherm probe. This is what is at the moment under investigation. Most of the devices are in the first in human series, and I show you now a couple of those devices. This is the flexible radiofrequency probe from Bronchus, and you see the flexibility. So when you find the way to the lesion, the probe is really flexible enough that you can insert it to that area you want to destroy. And this is how it looks. This is one of our patients. You see the nodule before. This was a non-surgical candidate, and we did the ablation. And this is how it looks post-ablation directly. And we also published together with the Chinese colleagues a couple of cases. The procedure went, you have the CAT scan, you do a navigation bronchoscopy, you see the lesion, you take a biopsy, you get the result within 5 minutes, you get a frozen section or rose, then you go in with the ablation catheter, you ablate the lesion, and then you follow up the lesion, and we really were able to show that most of the patients have been stable regarding the cancer, so radiofrequency ablation seems to work in our patient. The problem of radiofrequency ablation is that it's a long-acting procedure. It's a 60, 80-minute procedure. So the question is how we can improve the technologies that we're getting better and bigger ablation zones in a shorter time frame. And therefore, we combine this as a research project we're doing together with ÖBI. We're trying to combine the radiofrequency with the cooling of the cryo, that we can cool the tip of the probe better, so therefore we can decrease the procedure time and increasing the nodule, the target size. And you see these are data from the bench that we really were able to show to get 3 centimeter lesions within 15 minutes. Here again, this is frequency ablation without cryocooling and with cryocooling within 15 minutes. So it seems that hybrid term probes where we combining the cooling and the heating really brings the procedure time down and allow us to have 3 ablation zones, so we really can treat the whole lesion within the margin in an acceptable time frame. The alternatives are microwaves. The technique was also brought in by the radiologist doing that percutaneous approach. You see here an example from our radiologist putting in the antenna under CT control, and then you see how it develops over the time, the tumor shrinking. Now we have the first flexible microwave probes also available for the first in human trial. This was the so-called treat and resect trial. So this was a surgical candidate where we inserted the probe where we ablated the area, and then 1 week later the surgeon resected the area to see how really the ablation works. And it seems that even microwaves are working similar to compared to the radiofrequency ablation. So it might that might be the second technology, and especially for patients who have pacemakers who cannot use radiofrequency ablation due to the interference with the field. So therefore, microwaves seems an option for patients who are not candidates for radiofrequency ablation. And also there are techniques in the animal phase where you use only cryo. These are different gases compared to cryobiopsy. But the group from the Shanghai Chest Hospital showed in their bench work as well now in the animal work that with the help of a freezing catheter, they are able to achieve lesions up to 3 centimeters within a couple of minutes. So it also seems that cryo itself might be an option for our patients. So we have now 3 thermal technologies, which at the moment which are in the moment in the clinical trials show how good everything works. And maybe we also can use a technology we will talk about later when we talk about lung volume reduction, the vapor. So by vapor, we injecting at least steam into a segment, and when you do that in the segment who is at least then leading to the cancer lesion, you can get ablation zones like shown in the image. The advantage is that it's super quick. The procedure is finished after a minute when you finished, when you find your area, and it's super cheap because it's only hot saline. So therefore, it might be that we are seeing we will see the first human data published soon. It might be also that vapor is an option for the peripheral part of the lung cancer. So these are the effects which have already published. Here you see one from our patients. This was one of our first patients we treated, and this was also a treat and resect trial. So we treated, and a week later the patient was operated to see the effects, and we were able to, the pathologist was very able to show that most of the cancer cells were ablated by the vapor. So even there, vapor might be technology. So summarizing that talk, focusing on cancer, I think in the near future, we will have several technology will guide us to lung cancer or lung metastasis. And then we will have special patients where we do then the treatment endoscopically, and we will have various treatment options, and based on patient characteristics and lesion characteristics, we will decide which technology is maybe working best in that patient. So IP will also play an important role in so-called non-surgical candidates. And even our radiotherapists are quite happy that we starting a lot of those trials, because we normally start here with the endoscopic technologies, and only when we failing, the radiotherapist offers the stereotactic radiotherapy. The other way around doesn't work. When you have a patient who underwent the radiotherapy first, and you do then, and the regular CRP doesn't work, you cannot do an ablation technology endoscopically because the tumor or the tissue is too stiff. So therefore, the flow will be the other way around. But for the second half of my talk, I want to change the topic. So moving to the COPD field. So we knowing that COPD is a progressive disease, and we have two subtypes, the pink puffer and the blue bloater. So more the chronic bronchitis or more the emphysematic part of the population. And this is the development of the inhalers. But since we have had the launch of a LAMA in 2002, we haven't seen any really new. We only seeing the combination of A and B and C, and since 2 years we have now the triple therapy, but we do not have any new drug or any new theory in the pharma world. So pharma is running out of any additional option. So therefore, we have to think about endoscopic solution, and the first solution came up was the endoscopic lung wall reduction to make the lungs smaller, to improve the exercise capacity, and therefore change the mortality signal. So we have three different technologies. We have the valves, and for the valves, they are CE marked and FDA approved. We have the coils, not longer the BTG coils because they lost the market and they do not have an FDA approval. And we have the vapor, which is CE marked but not FDA approved. And those are the options we can use for endoscopic lung volume reduction. The most used technologies are the valve because we have the best evidence for the valve. You see, this is a movie from 2004, so we started early, so we still have the same movie because the technology is not really changed. You go in, you put the valve in that you block the flow into a whole lobe, and then what happens, you can see what happens when the patient is exhaling, then the hyperinflated air is pressed out. And when the patient is inhaling, then it doesn't refill. So we have, as mentioned now, several controlled trials showing that we can improve the exercise capacity, that we can improve quality of life. We have to accept that the major complication is a pneumo directly after the placement in about 20-25%, but no other complications. So therefore, the FDA and EMEA approved the technology, and the valves are nowadays accepted. The other technique we have had have been the coils, where we have seen various data. You need 10 of those devices. It's a bilateral procedure. But unfortunately, Numerex sold their patents to BTG. BTG was bought by Boston, and Boston is not longer interested in or to offer the coils. So the original coils are disappearing from the market, but there are a lot of other companies working on similar products. So these are the products we have at the moment in first in human trials, and the Chinese coils is now available on the Chinese market. It's turning a little bit different compared to the original coil. It has a sheeting, so the whole device looks a little bit different through the coil. So this have been the animal data which have been published. We already started with our trials using that coil, second generation. It works similar than the coils before worked. Due to the reason that it's a Chinese product, the product is cheaper. It's not longer so expensive than the original one. So coils will be back soon because the company is now looking with our data for CE mark, and then they can start selling in Europe, and for sure they will contact you in Turkey because also you used the coils in the past, and we will have in the near future new coil options for our patients. And the last technology we are using are is the steam. The mechanism of action is a little bit different to what we normally doing, because we're going in the most destroyed subsegment, we injecting the hot water. That leads to an inflammation, and that inflammation leads to the shrinking and then to the reduced hyperinflation. So that means that the process takes a little bit of time. Also, a lot of animal work was done. Here you see how it works in the animal. When you inject really the hot water, that you really see that the shrinking starts and the fibrotic changing will occur within 3 months. And what we learned with the vapor is that we should not treat the entire lobe, what we did initially. So we should look for the most destroyed areas in the lung. So therefore, we're using it nowadays in a so-called step-up approach. We're looking where are the most destroyed areas in the upper lower lobe, left or right side, and then doing multiple sessions. We titrating the technologies until the patient has been enough effects. And this have been the data we have published a couple of years before, Pallav Shah and myself, really showing that it makes a lot of sense to do that step-up approach, that you can increase the quality of life in those patients, that you can improve the lung function of those patients, and that you really have a good 3-year survival when you use those technologies. So even vapor is an option, and vapor will be used in multiple sessions because you really have the chance that you can use it as long as the patient shows enough benefits. And the other good signal for the vapor is it's maybe the technology with the lowest AE rate because due to the reduced dosage, we do not have any severe inflammatory responses in the population, so it's even safe. But we're also looking for technology for the other phenotype of the COPD population, for the chronic bronchitis patients, those patients suffering on the mucus and repeated exacerbation. And the technology we are using therefore is the so-called rheoplasty. This is the delivery of solids within microseconds. We titrating that with the cardiac cycle, and then we're getting disruption of the membrane of the glands, and then the glands are destroyed. And you see what happens to the patient. This is the patient before, and this is the patient 3 months later. You see no more mucus. The patient has a lot of benefit. So the technique itself is it's quite simple. The technology is comparable to the thermoplasty, from asthma. You go in with that catheter, you deliver the energy, then you close, then you pull it back, you cave again, and you deliver the energy again. So it's another 45-minute procedure, and do the one side at one time, so the patient gets bronchoscopy. So even that is step by step by step. But the effects are quite convincing, quite amazing from a patient perspective. And the other technology which is competing to the rear, spray cryo. This is with oxygen. We just bring in the bronchial system, freeze the bronchial system down to 173 minus, and even that destroys the gland. And we are also using in the animals the vapor, different dosage and with a different catheter, because we also have seen that with the vapor you can specific layers of the glands. So we will have in the future 3 technologies we can use to reduce the amount of glands, and that is for clear a therapy for patients with bronchitis. We do not have any good results at the moment. And COPD patient, we have the target lung denervation. That means that we're going in with a radio, we are ablating the vagus nerve, so there is no more bronchoconstriction. Even that based technology, you go in the bronchial system, you fill up the balloon with, the balloon is filled up with ice water, filling the balloon, you press wall, the electrode covers 90 degrees of the bronchial lumen, then you deliver the energy, and you control that during endoscopy, how the catheter is placed, bronchial system, then you rotate the catheter, and of the, and then after first in the side, move to the right side and do the ablation to the lung innervation also in left. DJ Levels published our 2019, and you see we were able to show that patients who underwent the target lung denervation have a reduced amount of exacerbation. So the trial was quite successful, and the trial also reached other therapy, all other outcomes, secondary outcomes like St. George and 6-minute walk. At the moment, we are in the F2 trial, which is the pivotal trial, and hopefully that technology will be available soon. And we also have a lot of technologies at the moment. So for the smooth muscle type, we have the approved in Turkey and used in Turkey, but we also have trial running with the target lung. We also have technologies targeting the epithelium, like the rheoplasty, the these are technologies we will have for our asthma patient, and are familiar with the pneumology technology mentioned that is available in Turkey in energy, and by delivering a specific energy specific temperature of the airways, and by the temperature you destroy the muscle, so therefore you get a shrinking of the muscles, and there are also multiple data showing that it really works. Again, it's a procedure where you have to, it's a procedure where you have to do 3 bronchoscopy, start with the right lower lobe, then in the second procedure, in the last procedure, both upper lobes, and even you have to do a lot of activations that the patient has a successful procedure, but also for we have nowadays good solution. Summarizing my talk, I hope I was able to show you that our field of intervention is growing. Initially, we started as having diagnostic options, but now we're moving clearly forward in the field of therapeutic options. So we will have in the near future options for our lung cancer patients, lung patients. We have for our CBD patients, for the emphysema patient, but we will providing the data that we get approval of the chronic bronchitis therapies as well of the other asthma therapies. Therefore, interventional pulmonology has a fantastic future, and I hope that you in Turkey can be part of the game, and also in Turkey we can really do research together. So therefore, thanks a lot for attention. I'm happy to take questions.
Thank you for your impressive presentation, Felix. Questions?
Can we ask our question with the microphone, or?
Yeah, I can hear you. Whoever just.
Okay. Professor Felix, thank you so much for your very nice presentation. We really enjoy it, and I would like to ask you about: are we going to become a good, strong competitor with radiosurgery specialists about peripheral solitary pulmonary nodules with our microwave ablation and others?
Yeah, you are right. So I think what with the radio frequency ablation we showed now in a couple of first in a couple of treat and resect trials that we are able to treat all cancer cells. So when you go in, we really can ablate the whole lesions, and therefore we will be an important player, and we will be clearly competing with the radiotherapists, because in all those lesions you need a diagnosis.
Okay.
And when we can do the diagnosis in that patient with the bronchoscope, the staging by using the eboscope, so we know it's in an N0 situation, and the treatment in one session, then we are really way ahead for the radiotherapists, because they need a diagnosis. So you can do a bronchoscopy, or they do a CT guided needle aspiration. Then you have to do the staging of the mediastinum, therefore you need the scope. And then you have to do the radiotherapy. These are three procedures. So what we believe in will be the future. We will do a PET scan. We will do an MRI of the brain. And when there are no distant metastases, we will go in doing the biopsy of the peripheral lung, doing the EBOS in the same session, doing that with Rose. And when we're getting the non-small cell lung cancer approved and no involvement, we do the treatment in the same session. So therefore, the treatment must be short, that the procedure is not too long. And therefore, I believe that that combination of cooling and heating might be really a good option to that.
Okay, thank you. Thanks so much for your answer.
Another question?
Yes, there is. Sedat abi burada yazıyor. From Dr. Talat Kılıç, he thanks you very much, and his question is, what are your thoughts on the use of EBAS in the diagnosis of lymphoma?
Yeah, this is a very good question. So for lymphoma, we need a lot of tissue. And therefore, the 21 gauge needle do not allow us to take out enough tissue. So when you want to use the EBOS for the lymphoma diagnostic, you have to use one of the newer, the bigger needles. With the 19 gauge needle, you can do that. So and we will have, the company is working on 17 gauge needles. So the needles get bigger in the near future. So when you go for lymphoma, then you have to use a big needle that you get enough material out, and you get a core cylinder out, but then you can diagnose lymphoma, but not with the normal needle.
Okay, we have another one from Akif Turna, Cerrahpaşa from Istanbul. He's a good surgeon. What percentage of the tumor can be ablated by radiofrequency ablation? Do you perform radiofrequency ablation without diagnosis?
No, so we need so I have to know what I do. So therefore, diagnosis first. And at the moment, I think radiofrequency ablation is only an option when the patient is a non-surgical candidate, too old, too many comorbidities, or COPD. So when the patient is not a surgical candidate, then we're going for radiofrequency ablation. When he is a surgical candidate, then for sure it's a surgical candidate, and we're sending the patient to the surgeon. But diagnosis first.
Yeah.
Okay. I see another one from Sertaç Arslan. He thanks you first. Then his question is, what do you think about the usage of EBAS for the biopsy from esophageal route? For example, the clinics which does not have EAS, for example, the lymph node station number 8.
Yeah. So for sure, when we're doing that quite often, that we start with the eboscope in the airways, and then we just using the eboscope, the same scope in the esophagus to reach the other station. So I'm completely fine for lymph node station 7, 8, and also lymph node station 4 left. You can also go by the esophageal route. But the lymph node stations on the right side, you reach via the esophageal route, or you have to use it in the airways. But I'm completely fine with using the ebuscope via the esophageal route.
Başka bir soru yok herhalde.
Sedat Hocam ben
Buyurun hocam.
Felix, it's very nice, excellent lecture. Thank you very much. I am sure that our colleagues can have a very good knowledge from your lecture. Endoscopic asthma treatment is very interesting. Which patient is available for this treatment? Chronic asthma, steroid-resistant asthma, or severe asthma?
So the reason that we have a lot of biologicals for the eosinophilic asthma. So we're using in those eosinophilic asthma IgE as an IgE elevated patients, we first use biologicals, and only if they are not working, we're using the thermoplasty. But in all neutrophilics, so in the non-eosinophilic severe asthma population, which are needing high dose of corticosteroids, nothing helps. In those, we are using the thermoplasty, and with quite good results.
Thank you. Another question, can robotic bronchoscopy be performed under local anesthesia or general anesthesia?
General anesthesia.
General anesthesia.
So at the moment, patient must be intubated, and you need a general anesthesia because the robotic system is connected to the tube. So you need a fixed point, and then it's moved forward and backward. Yeah, it's general anesthesia.
Thank you again for this nice lecture.
Thanks a lot.
Zafer Hocam, benim de 2 tane sorum vardı ama.
Hocam lütfen sorun. Siz direkt sorun.
Peki. Felix, thank you for your innovative lecture. It was very good lecture. I have 2 questions. One is, you mentioned about radiofrequency ablation, microwave ablation for peripheral tumors. In the maybe not near future, but in the maybe so many years later, will we be able to diagnose using optical coherence tomography or endocystoscopy these peripheral tumors, and in the same session ablate these tumors by using microwave or radiofrequency ablation? What do you think about that? Is it too utopian or?
No,